Hi, I'm Bronwyn Williams. We're back with a small print, and today our guest is Anja Smith. And as always on this show, we like to ask our guests to introduce themselves the way they would like to be introduced. So over to you.
Thank you for the opportunity, Bronwyn. I self-identify as a development economist, and that, I think, in brief, basically means I've spent the majority of my career focusing on the social delivery systems that either help people move out of poverty or prevent them from falling into poverty. And this includes financial services, the financial sector, health services. I think I've also done some education work and interested in the question of public delivery more broadly, and the incentives and processes and role players that shape public delivery systems. I did a PhD in economics at Stellenbosch University and received it in 2016. And the PhD was focused on various questions related to the South African health system, ranging from health financing, healthcare delivery, and user acceptability. At the time, my supervisors and I felt it was very contentious to talk about healthcare quality. So we packaged the quality elements in the term user acceptability. But things around healthcare quality sort of changed in I think both the local and the global narrative changed very rapidly after that.
Yeah, fantastic. And do you work independently at the moment, or do you work with an organization? If you want to give a shout out to any of your projects, I mean, the platform is yours.
So I work for a very interesting multidisciplinary consulting firm called Percept. Percept was started by actuaries Shivani Ranchod and Dave Strugnell, who have really deep expertise in the health sectors and the financial sectors of South Africa. And I get to work with all sorts of interesting colleagues, ranging from public health specialists to other economists and medical anthropologists. And we really believe that the strength, I think, of our work lies in our multidisciplinary lens and approach. And I'm also affiliated as a researcher to research on socio-economic policy, or RECEP, at the economics department of Stellenbosch University. So I have a researcher role there, and I lecture in health economics. And I think the last thing to note, just in terms of affiliations and shout outs, is a lot of the work I'm going to be talking about today was funded by an organization called the Inclusive Society Institute. And at Percept, we've been doing a series of 4 reports on universal health coverage in South Africa. And I understand that is really going to be our focus today.
Exactly. So there's no surprise why we invited you to talk about the sort of impending conversation that's come more and more to the fore around the question of national health insurance, particularly in a South African context, but also, as we alluded to a bit earlier, also the biggest sort of global picture here. Because the reality is, when it comes to healthcare, I know you said that the words like quality around healthcare can be a bit contentious, but really that is the case, that both in terms of quantity and in terms of quality, the demand for healthcare is really infinitely elastic. But however, when we're dealing with public sector money, funds are not infinitely elastic. I mean, sure, we can manipulate money supply and print as many zeros as we like on the end of our checks. But the reality is that healthcare is a scarce resource, and it's very expensive, in both in terms of real resources and the research and development that goes into it, and also in terms of the physical labor that is required to actually deliver that healthcare service. So from an economic sort of perspective, it is a really big challenge, and it's one of those knotty, political, messy problems that don't necessarily have a clear-cut sort of moral right or wrong answer. Although on the surface, conversations usually go like you can't put a price on a human life. But when it comes to public sector funds actually deploying that money, that's kind of exactly what we're doing. And these are conversations that are being had across the world in some of the most advanced economies that have the most generous and the most sophisticated public healthcare services, like, of course, the NHS in the UK, where they have those infamous, for example, sort of death boards, as they're called by the popular press, that actually have to make the hard choices as to who actually gets the scarce resources when you have this infinite demand for the services. And that's probably one of the questions I wanted to get into with you. Maybe we can start there. Let's start with what's uncomfortable and then see where the conversation goes, because I'm certainly not a PhD supervisor. So contentious issues are basically our bread and butter here. And the question is exactly that. Like, when it comes to trying to nationalize health services, we are asking bureaucrats or the government or a central point of authority to make decisions really about life and death. It's about who gets the quality of healthcare and who gets the quantity of healthcare. And that, of course, means that we lose quite a lot of the market dynamics. Whereas if you've got alternatives in the private sector, people who are prepared to pay more in terms of their own sort of resources in order to get the quality and quantity of healthcare that they want for themselves, is a very different question to when those decisions are trying to be made at scale and trying to be made to flatten the playing field and to make sure everybody gets what they need. And we immediately run into issues of scarcity. So I wanted to start off with your broad thoughts as to the proposal that has been put on the table for NHI in South Africa, based on that sort of context that I've sort of outlined over there. And from a very macro viewpoint, can you summarize your viewpoint or the viewpoint of the research that you have been involved with bringing to light with regards to the problem on the table? What is the reality? Because we have to formulate the mess and understand the real trade-offs before we can make any sort of smart choices as to what's right and what's wrong and what's affordable and what's not.
I think you're asking amazing questions, and economists love questions about scarcity. I mean, I think, if you study economics, you know that is really what the first lecture in economics is about, the fact that resources are not finite. And what many South Africans, ordinary South Africans, don't realize, and I think especially those South Africans that utilize the private sector, is that healthcare services all across the world are rationed. And systems use very, very sometimes formal, but also informal ways of rationing healthcare resources. So I think in South Africa, we are very aware when we think of the public sector of extremely long waiting times. And actually those waiting times standing outside a facility in a way becomes a rationing mechanism. Who is willing to give up a day's wage to go and stand outside a healthcare facility for many hours in order to be serviced? We have waiting lists in the public sector for certain, I think, essential procedures, as do many countries, also many high-income countries in the world. I think the private sector, for South Africans fortunate enough to be able to utilize it, actually often creates the illusion that there are more resources available for healthcare services than people realize. But these life and death decisions are made every day. And in fact, I actually think COVID exposed many of these life and death decisions, when it came to decisions around the rationing of ventilators. Often those decisions were age related. When you have to make a choice between a 25-year-old patient and a 70-year-old patient, who do you give the ventilator to? And before I think these stories were documented in the media, these decisions were made every day anyway, in very informal, intuitive ways across our health system. People just didn't realize the extent of rationing. Whenever I lecture masters, postgraduate students about health systems and health expenditure and the relationship between expenditure and outcomes, I make it very clear, and you can clearly see it in the international data, that there is a certain expenditure threshold beyond which it becomes very hard to achieve massive marginal benefits to additional expenditure. Yeah. So there's a very quick tapering off in the steepness of that curve in the relationship between healthcare expenditure and outcomes, especially in certain sort of critical areas like maternal health, child health. I mean, I think there's always non-essential procedures where you may see other relationships, but in the healthcare outcomes that societies really value, more money isn't necessarily going to achieve much better outcomes. And it's also interesting to look at the outlier countries in that context, because you can clearly see when you do those scatter plots, there are some countries that are doing a lot with limited resources. And then there are countries, often sort of the countries in Africa that are very reliant on oil income, that are, where there are very high levels of expenditure and very sort of poor health care outcomes. But if we take it back to national health insurance and the question that our country is being confronted with at the moment around how do we really work with the resources we have in a very tight fiscal environment, I think the stark realization that more money won't necessarily buy better outcomes unless our systems and our quality improves hasn't yet sort of come to the surface for many stakeholders in this conversation. I think, of course, we need to create much greater equity between the public and the private sectors, and the flow of funds needs to be equalized in some way. But the question is whether more money, given the way, especially our public sector is currently functioning and its ability to effectively and efficiently absorb that money, will really make a difference.
Yeah, I suppose that's the first question, is are we spending comparatively compared to the rest of the world? How does our allocation towards healthcare compare at a public sector level? Are we spending too little? Are we spending too much compared to the sort of general average of what's going on in the world?
I think there's definitely scope for increase. So we're currently, in the report, we say we're spending 8.7% of GDP in healthcare if you add up all healthcare expenditure, public sector, private sector, out of pocket. And often people, when they think of private sector, they think just of medical schemes. But the reality is many people who are not members of medical schemes also fund healthcare services on an out-of-pocket basis through visits to pharmacies, outpatient visits to GPs, and so on. And I think that is the component that people often forget about when we talk about the overall composition of our healthcare expenditure. In South Africa, the thinking about the health system is often just one of these two polar opposites, right? There's the medical schemes that provide coverage to 16% of the population, and the number that's often cited is, more than half of healthcare expenditure goes towards the 16% of the population. And then there's the other 84% of the population that's funded by the remainder. But both, I think people who typically use the public sector and who use the public sector actually spend on a private sector basis. And I think that often goes unrecognized, that if you urgently need care and it's going to entail spending the majority of your day in a queue and you have some money, you're going to bypass that system and rather pay for it on an out-of-pocket basis. So just to get back to your question, I think, which was about
how does South Africa compare in general to the rest of the world? Are we
the rest of the world? I think there's scope for increase, right? So I think there's definitely scope for increase in terms of our percentage of GDP. But I think it's marginal, maybe I think in some of the documents where people write about relative expenditure and sort of the relative threshold South Africa should aspire to, it's as high as 12%. But the question is, what are we trading off if we think about, and where are we going to reduce public expenditure to enable the increase in healthcare expenditure? And if you think of our social delivery systems, I mean, I think apart from health, the system that is most in trouble in the moment, or at the moment, is our education system. So there's I think, strong competing demands also just from a broader social development perspective, if we think of the welfare or the grant system and discussions currently ongoing around a basic income grant.
Yeah, because it's all choices. You have to choose to deploy capital here or there. You can't have and always, or you can have and, but then you have less quality across the board. And it's probably also worth pointing out the difference between South Africa and some of the countries that have the more sophisticated healthcare systems, in that they also do spend quite a lot more in terms of percentage of GDP on those systems, but they're spending a lot of that spending right at the end of life years. In other words, the amount of capital you have to deploy to keep an 80-year-old alive to sort of 82 is a lot more than you have to deploy to get someone to 65. So we're not even at that sort of point yet here in South Africa. But those, as you said, those marginal returns to actual quality of life years, they do diminish quite dramatically. So they are points where you could say, like, that's actually probably enough from a social perspective that we should be spending on general healthcare. But then you still need to have enough fat in the system for individuals to make those choices for themselves if they want to sort of spend the exorbitant millions of rands on an experimental sort of cancer treatment that might increase their life expectancy from 12 months to 18 months. Those are sort of decisions that are probably best decentralized because they don't have the same sort of scales to overall social returns. And of course, it's very crass to talk about these things, but that's what policy is. It's about making the hard choices as to whether you give extra food to a single mother or whether you pay for extra healthcare for a 75-year-old man, for example. These are the choices that this is how it devolves to the individual level. And I wanted to come back to that point about choice. Like you were saying, that the part that people forget about is the fact that a lot of discretionary medical spending is not taking place just with the sort of luxury healthcare, sort of buying luxury healthcare and increasing quality of life when other people could have their lives saved, end of the spectrum. It's also being done by the poorer people of society who are paying to bypass systems that, if left to their own devices, simply couldn't actually save them or get them out of the situation that they want. And that by nationalizing everything, you're kind of removing the ability even for the most vulnerable people in our society to take matters into their own hands in the event of an emergency. And we all know the terrible stories of people that have died in waiting rooms or babies that have been sent away from clinics because it's not Mother-Child Day, only to have really disastrous outcomes. And those are the sort of people that, by removing the discretionary ability, not just removing the ability to get like a luxury nose job in Spain, you're kind of removing the ability for a mother to take proactive action to save her child. And I think those conversations are worth having because we tend to think of things in such sort of binary, sort of rich versus poor kind of perspectives. And I suppose there's also the point that even if you are going to sort of try and flatten the private and public sector sense, there's also then the question of the attractiveness of people buying into that social contract, which is something that I've spoken about quite a lot, in that you have more mobility at the upper end of the scale. If systems change and are no longer suiting the most wealthy people in society, they have the ability and the incentive to opt out of those social contracts. So if you are no longer able to have like your private medical aid and to have the choice in that sense, or you do have the option to get on a plane and go to another country. I mean, this is what happens in Canada, for example. Canada, which has like a national healthcare system, whereas its neighboring country, America, doesn't. And wealthier people, when they get on a waiting list for, say, a transplant, can bypass that system by bypassing the social contract altogether, getting on a plane and going to Los Angeles to have the procedure done instead. Those options still remain for the wealthier people in society, even if you take away the option of privately funded healthcare. Those options get taken away from people further down the scale that can't afford the much bigger difference now between the basic level of healthcare and the rest. So that was what I wanted to get into, I think, a bit more today, and that you had proposed with your research partners and the people that you've been looking at this issue with, a few alternatives to the sort of single payer system that is being presented by policymakers in our country. I think there were 4 different alternatives you had that mixed and matched this in different ways, but still left some choice on the table for individuals to make those sort of infinitely elastic choices for themselves, but still then level the playing field on the basic access to healthcare, the kind of getting children to adulthood and getting adults to sort of 60, 65 plus year lifespans, which should be the priority of any policymakers, but perhaps leaving those sort of tail end events that can end up being very, very expensive to more individual choice. So I hope I'm sort of articulating the position, at least like slightly in the direction that you wanted to go to, and feel free to correct me. But if you wouldn't mind taking our listeners through what your alternatives are and how they are distinct, because when you sort of read the press releases to a layperson, they all kind of sound quite similar. So what are the actual options that we could be looking at where we could get more health for our very scarce resources?
Happy to outline the various options. I think I'm just going to start by saying that I want to make it clear that the NHI bill, as it currently stands, is not proposing to do away with private healthcare services. It's not taking that position at all. It is basically proposing to do away with the pooled approach to private healthcare financing as it currently exists in South Africa, namely the medical scheme sector.
Medical scheme, yes.
And it's basically saying that once NHI exists, there will be no more medical schemes, basically.
Private medical aids,
yeah. So I think, private healthcare services will always, exist. Even if they become illegal, they will exist in some way. Even if ships have to pull into Cape Town and Durban Harbour, and we have medical
doctors
ships.
become the new hairdressers with their special WhatsApp groups and their sandwich deliveries. Yeah, exactly. I mean, like, people find ways around.
Yeah, but I agree that I think the political economy of health is such that people who can afford to access private healthcare services will do so. And, they may get on planes, they may cross borders, they may go onto a ship, but they will find a way. So the 4 scenarios we propose, actually in an earlier report, even before the costing report, they use the departure point of NHI as positioned in the bill. So that's sort of as described in the bill, that's the baseline scenario. But then there are also 4 other scenarios. So the first is basically status quo gold standard. So it assumes, what if we just use and improve our health sector as it is and implement certain quality improvement steps? We improve the public sector infrastructure. We start to roll out really good and comprehensive information technology and data systems to actually enable us to monitor the use of healthcare services and public expenditure spend much better. And there's also, the potential for actually implementing the proposals made in the private health market inquiry report. So there were actually many proposals to stabilize and lower costs in the private sector that were made in that report that haven't yet been implemented at all. So the first
use the money we're already spending, but better, reduce the fats in the system, get rid of some of the corrupt tenders, and actually deliver on what we've already paid for, in other words.
Yeah. So I mean, I think we have to be clear that there are not only problems in the public sector, there are also big problems in the private sector. And, the typical payment model in the private sector at the moment is still fee for service. It incentivizes massive overutilization. we have documented instances of supplier-induced demand. So I want to move away from the narrative that they are.
Well, it's essentially the same question, right? Because that's what we're getting at. So the problems in the private sector are generally because you've got massive buyers that are buying on a group collective and executing essentially monopoly power over the marketplace. And it is slightly ironic if you take a very outsider view, that the way to fix this is by putting an even bigger monopoly in place and actually reducing cost, right? So like the biggest problems in the private sector can't be really solved by replicating that model on a public sector basis. I think like choice becomes very critical, and any choices with regards to personal health. There's nothing more personal than your health. So I think that's probably a helpful way to frame it. So again, not binary, not like public versus private, but what is the actual problems in the system? And a lot of the problems, whether it's corruption in the public sector or whether it is gross inefficiency and probably graft in the private sector, are following the same basic incentives, and the fact that when you've got these oligarchies or these monopolies in place, then efficiency does tend to be slightly reduced, to put it politely.
Yeah, I think I can agree with that there will be a reduction in the incentives for efficiency. And actually, I think the points you've now put on the table are a very nice lead into our third scenario, power to the people. And I'm going to get to that in a moment, but I'm just sort of sequentially going to talk through the scenarios and how we see and position them. So the second scenario is a scenario we refer to as NHI reject. And basically, this scenario assumes that we take some of the basic ideas as put forward in the NHI bill around universal health coverage, bringing the public and the private sectors together, and we do it in a different way. So we do it in a far more gradual way. So there are longer timelines than the timelines envisaged or put forward in the NHI bill. But we also I think we speak to some of the accountability concerns in the NHI bill. So we can talk about, I'm sure you're going to ask about accountability later, especially also when we come to NHI reject. And you implement certain also of the stabilizing steps and regulatory actions needed in the private sector. So, but you basically improve and you speak to the major concerns around the NHI bill, and you take a different approach. The third scenario, power to the people, is quite similar. So longer timelines, more gradual approach, not the big bang approach put forward in the NHI bill, but then it proposes going for really a multi-payer approach, where you can imagine potentially something like 3 different big medical schemes, of which the government fund can be one fund. And I think there are many ideas about how one creates sort of such a public fund, and the NHI constellation, or the universal health coverage sort of public sector policy and constellation, contracts out the payer sort of payroll to at least 2 other medical schemes. And who they are, I guess, that's an open question. I think people who are listening to this conversation may have some hypotheses, given what they know about the landscape of the current South African medical scheme environment. But then you essentially have these funders compete in terms of quality, the nature of service delivery to their clients. And you can even think about sharing some of the performance indicators publicly a few times a year, once a year, and also giving clients of the system. I like to talk about clients when I think of the healthcare system. I think patients can often be a quite disempowering word, but you give clients the option to switch between these funds maybe once a year. Because the NHI bill is currently very silent on bottom-up accountability mechanisms. And if we look at accountability, there are different ways of doing it. It's very strong on a devolution of authority from the top, sort of top-down accountability approaches, but almost completely silent on bottom-up accountability approaches.
Can you give some examples on that bottom-up accountability? What does that mean as an economic sense for those who are not following?
So I mean, I think it's very close to what I've described, giving users of a system a choice around maybe the funder or not the funder, actually the payer who is buying services on their behalf and contracting with providers, giving them a choice about who they actually which fund they actually want to belong to. And I think it also entails much greater transparency and accountability of information. So if you think of the German system, for example, and one of the reports we did for the Inclusive Society Institute actually focused on lessons South Africa can draw from Germany's sort of very long road to universal health coverage. And what they do around information sharing and transparency is they actually publish the mortality indicators of hospitals publicly. So people, and of course, I think it's, risk-adjusted mortality in health. We always have to risk adjust. But that data is in the public domain, and people do have some choice also, depending on which fund they belong to, in which hospital they go to. So I think choice to users is a very important component of bottom-up accountability.
How similar is that to the, sorry to interrupt you, to the Obamacare sort of proposal that was put in place, which is also a journey towards, because America doesn't have full national health coverage, but that was almost like an interim step towards it, where they sort of had government endorsed funds that people got to choose from. Is that similar, or is that a different way of thinking about it, what you're proposing?
I think it is potentially quite similar. I think it relies on the same types of principles. And obviously, I think the government endorsement does sort of almost give a stamp of approval, and someone has considered the functioning of this fund and sort of applied whatever lens of scrutiny to it. So I think there are similarities at a principle level.
Yeah, but so limited choice, but also at the same time a compulsory participation. Yes. So it no longer becomes an option, it becomes compulsory. So it almost becomes a tax, but it's a tax where you get to sort of choose where to put your tax money instead of giving it all to the central authority to sort of distribute to the various different players.
Yeah. So I think at a principle level there are similarities. And bottom-up accountability will always rely on information flows, right? So there has to be an information flow from the client, or the user of the services, back to the system, and that is built in much stronger in our last scenario, sort of reorienting towards value. So I do think the power to the people sort of is it's really a first step to get to strengthen bottom-up accountability, but there are other ways of strengthening it even more, where you explicitly measure patient experiences and patient-reported outcomes, and you actually tailor payments according to some of that information around patient-reported experiences and patient-reported outcomes. So it's really just a very, very first step to give some choice within a public health delivery system. Okay, so that is scenario 3. Scenario 4 is reorienting towards value, and I've actually started to touch on it now. And it's very similar to the power to the people scenario, but it assumes that we get the health system to pivot towards a value-based care approach to healthcare delivery. And value-based care essentially assumes much greater alignment of the incentives between funders, payers, and patients or clients of the system. It assumes strong feedback mechanisms from clients around their experiences, and actually using that information and data to tailor patient pathways and the type of care delivered to patients in a way that optimizes value for the system. So it assumes you have very strong and good information and data systems, but it also fundamentally assumes another way of delivering care. And that is through often multidisciplinary teams. Especially in the South African private sector, we have a very strong reliance on individuals. So, there is a doctor and there is a specialist, but rarely does healthcare get delivered in a team context where there's a group of people from different disciplinary perspectives actually taking collective responsibility for a particular patient, especially if that patient has a more complicated condition. So you spoke about the overuse of end-of-life care and the very high levels of expenditure on that earlier in this call. And I think there's now a very strong recognition that death has essentially, and the process of death has become medicalized. And there's a strong, I think, global resistance emerging towards that. So Lancet has actually just published some very interesting pieces on that. But if we then apply the idea of value-based care to end-of-life care, and this is some of what my colleague Shivani is doing in another company called Aligned. You would bring a multidisciplinary team to caring for a person who is essentially, for example, dying of cancer, as stage 4 cancer, and all the medical specialists agree that this person is nearing death and they have limited time remaining. And that multidisciplinary team would be constituted of a palliative care GP. There may be a specialist, there may be some spiritual representative dependent on the religion or the beliefs of the particular patient. There may be a social worker involved to support the family. And the patient would be empowered to actually make choices about the way they want to die in a holistic way, and avoid a long, very expensive death in a hospital. So you can apply sort of the same type of principles to other areas of healthcare too. You can think of maternity care, combination
and letting the patient choose what they value most. Because to go back to the sort of terminal cancer case, at that point, you've got kind of a choice between, say, having maybe 6 months of a reasonable quality of life, or perhaps at a long shot, maybe 2 years, but at a much lower quality of life, because the medicalized process is not pleasant to go through. And those are not easy choices, but they're certainly not one-size-fits-all choices that should be made by a third party. They should definitely be made by the patient themselves over to what they value most and what their preferences are. So yeah, that question around preferences around the tail end cases, it's quite easy when you talk about the middle of the bell curve. Like everybody needs maternity care, like basic maternity care, right? You need your 3 scans. It's very difficult when it comes down to so how does the birth process take place? Does everybody actually need a hospital bed, or can we do other things with midwives that are cheaper? And can we distribute that according to using market principles, right? To match utility to where people actually value it, because quite often we get services we don't need in the medical system. We don't really have a choice over it, because that's the only way the linear system works. So even at any end of the scale, the wealthy private sector or the public sector, there's a lot of wastage because of process that has been optimized for tail cases rather than from sort of individual choice.
Absolutely. I mean, I do think individual choice should be some part of it, but if we think of a system that has to serve many people, I think maybe individual choice in the end will come down to 2 or 3 options, and there are likely to be clear algorithms involved. But I think choice at some point of the care continuum will make patients feel more empowered, and it's likely to significantly improve their experiences and the experience information they feed back to the system. And it may end up saving lots of money. I mean, if you think of the way our private sector delivers maternity care, there's a complete over medicalization of maternity care. Our C-section rates in the public sector are off the charts. They're comparable to countries like Brazil, with also very, very high. And
having been through that system and being oversold products you don't need, you have to fight very hard actually to save everybody time and money, with no worse returns to outcomes. It's the system. A lot of these incentives are what are really bad. In fact, the incentives in the healthcare system are quite closely linked to incentives in the legal system. These things from a systemic point of view are very, very messy problems. But I think that what you sort of zero in on when you have these conversations, a lot of the wastage can be quite easily solved by actually looking not just at the healthcare system itself, but around the infrastructure around it, and the norms we've kind of set up around insurance, not just medical insurance, but also sort of malpractice insurance, and all of those things feed into it, and road accident fund. It's a very messy problem, but a lot of that wastage is exactly that. It's pure wastage. It's been set up for good intentions, but incentives don't really care about our intentions much. We have to design systems that incentivize the right things.
Absolutely, and I think we're fully on the same page. Talking about systems get me very excited. And if we think about healthcare in South Africa and the way it's regulated, I think what has been absent is a systems lens, and I think that in effect could be the game changer. So I think I'm very, very aware that there are extreme information asymmetries in healthcare, and the only way you can actually even try to begin to address them is through proper regulation. Otherwise, costs and I think exploitation of clients will spiral out of control. So you do need a middle ground, a middle sort of regulatory approach and ground that allows sufficient change and innovation for the system, but that also weighs the interests of the various stakeholders in trying to arrive at a Pareto optimal outcome. And that is a very hard thing. And if you think about our health system and who the regulators are, the National Department of Health is the regulator of the health system in South Africa. The Council for Medical Schemes is the supervisory authority for the private sector, but there's currently no entity applying deep thought to the supply side regulation of especially the private sector. Now, I think there are some rules and norms around the public sector, and that is one of the major shortcomings that the private healthcare inquiry actually pointed out. We need a health supply side regulator, and
on the competition side,
regulator.
Inefficiencies on the competition side, basically to keep an eye on things like antitrust and all the rest of it, right?
Yeah, and the price, the prices people are paying, even, is there just gross profiteering happening because of monopolistic providers? And I think we've potentially seen some of that around the cost of COVID tests. I think there's a lot we don't know that isn't in the public domain, but I can only assume that the Competition Commission took a position of having to weigh public interest and profit interests in in the final decision that was arrived at around the cost of COVID tests.
That information question is also something I wanted to touch on with you, because you've spoken a lot about sort of bottom-up like agency, but there's also bottom-up accountability that comes into the question, which is where, again, you sort of run into these very wicked problems from a public sector service delivery perspective. In that, we opened this conversation by talking about scarcity and scarce resources. But along with, if we wanting to extend rights to a greater sort of swath of the population, and also not just extend distribution of rights, but also depth of rights and access to medical care, the sort of elephant in the room, or sort of uncomfortable point that comes with that, is that those rights do come with responsibilities, and responsibilities for people not to abuse the system. So imperfect information in a medical context is not just the fact that clients of medical services are facing like very opaque pricing systems, that I see there's a lot of like regulation that protects monopolies in forms of patents and all of that. So there's also a lot of opacity in the way pricing codes are worked out. It's not just lack of access to information, there's a lack of sort of understanding what the information means. It's very hallowed the way that works. But that also kind of works the other way around in the whole sort of like lemons and peaches analogy, in that people, when you are paying your own medical aid, you have, even if you're in a private sector, you are still buying into the support of the community that is invested in that platform with you. And of course, that's why medical aids do great amounts of screening. They make you do tests. They nudge you to wear your Fitbits and run in the streets. They incentivize you to behave well, in other words, to reduce your drain on the collective pool. Now, the ethics of sort of nudging and behavioral economics and behavioral linguistics and occupational propaganda, whatever you want to call it, aside, the fact is that the private sector has access to those tools, and they can actually deny you coverage if you're not playing by the rules of the group, which is all fair and good. I mean, it's a trade you're doing, right? It's a financial transaction. However, those questions rolled up to a national healthcare level have very different degrees of ethical questions that come into play. We run straight into now, don't get to opt out of that system if you don't want to share your data as you can with a private medical aid scheme. And the company, or in this case, the country, on the other side, doesn't get to reject you if you don't do your part. So the trend in countries where you do have more nationalized health and single payer systems is for states to start demanding more and more privacy and data and tracking and rules around what people eat, what they're allowed to do. I mean, you've got carbon credit scores on like packets of chips, and you've got a whole lot of information sharing that states are starting to demand in a non-opt-out basis from citizens. And that's a hidden cost of increasing access to services, in that you are actually having to give up a lot of bodily autonomy in order to participate in these systems. And that's a real cost, and it's not a financial cost at all. But the point is, as soon as the collective is paying for your existence, basically, your quality and quantity of life, that collective has a right not only to get your information, but also to change your behavior, to put more rules over what you do. So it's not unforeseeable that not too far in the future, we might have like mandates of sort of exercise, like you have to do a certain amount of exercise a day. We've got technology to pick that up. Certainly there's technology to track what you eat. I mean, even just through your credit card, companies like MasterCard can tell how fat you are based on, you see quite a great degree of accuracy based on just looking at your purchase history or lack thereof, like what you are and aren't spending on. And those sort of questions, I suppose, are important when it comes to sort of single payer ideas, when it comes to limiting choice in the marketplace on a competitive space. In that monopoly, whether that is a private company monopoly or a public sector monopoly, has really, as much as consumers or clients have an infinite demand for quality and quantity of healthcare, there's a converse, almost infinite demand for information and for control. And the ethical questions around bodily autonomy have just come to the fore. I mean, like the vaccine debate is part of this whole conversation. We have states in the world that are like, well, we'll reduce your access to unrelated medical procedures based on your vaccine status, which makes sense from a policymaker's perspective because they're looking at the whole, they're not looking at the individual. But I don't know, from a societal point of view, I don't know if you have an economic view on that. That's almost more of an ethics question. That's kind of unfair to ask you. But does that play into your research at all when you put those proposals on the table that allow some choice, and by allowing choice, you're actually allowing some opacity, both from the company side and from the client side in the system. Is that part of your decision-making process, or are you really looking at the scarcity, the resources, the actual equations on the table? In which case, the perfect information question is kind of needs to go both ways. That's the way to get the most return on your information, is to remove privacy and to remove sort of opacity on both sides.
We looked at it from the latter perspective, really. I think a broader societal perspective around gaining the best or the maximum amount of benefits for resources spent. I'm going to respond to your question by summarizing my understanding of what you've asked. So the way I see it, you're basically asking about the extreme risks from a societal perspective associated with governments, or let's even say corporates, having too much information on citizens or people that comprise broader society. I'm going to answer the question from the perspective as a development economist and as a researcher, and not as a concerned citizen. I do think governments need quite detailed information on the way citizens engage with these services. And for a country like South Africa, I actually think the risk lies on the other side. We have far too little data in the public sector to be able to tailor public services to the needs of our population. So I would actually say, from a South African perspective, if we talk about the public sector, that's not something I have sleepless nights about at the moment. But I think we always have to develop regulation also for the future. And there is a growing global concern, especially in high-income countries, around not only governments but corporates having too much data and information on people's lives. And in response to that, there's also, I think, growing attempt to start to regulate the information sector more actively. So I think for South Africa, what we need to do or to anticipate is to move in that direction and to think about information regulation. The POPI Act is the first attempt to do so. But I think in the case of POPI, we've gone too far, and we may not fully be balancing the interests or development interests around access to information. I don't think as a middle income country, upper middle income country, we thought through the full array of consequences around policy development if governments cannot safely access the data of their citizens.
Thank you so much for joining us today and for being so generous with the wide-ranging questions and answering them. And we'd absolutely love to connect with you sometime in the future, and definitely will be following closely with your work. Thank you so much.
Thank you so much, Bronwyn. Go well.
If you enjoyed this conversation, please subscribe to our YouTube channel and rate us on all your preferred podcast platforms. If you'd like to find out more about what we're doing, please join our Substack community via the link in the comments below. And as always, we'd love to hear your suggestions for future guests and conversation topics.